Welcome, welcome, everybody. Thank y'all so much for joining us today. If I have never met you before, my name is Brooke. I am one of our program coordinators here at Alzheimer's Services, and we are so thankful that y'all joined us today for this really um, relevant information. And I get questions about this quite often through our helpline system. So I'm excited for us to receive this education today. This is, of course, a part of our ADAPT series, which we have three more presentations throughout the year. Our next one is going to be next month. So if you haven't registered for that already, I will send the link to register for it in our follow-up email. For some housekeeping for today, if you've never attended one of these presentations, kind of our style is our presentation is recorded and posted on our YouTube channel afterwards. Your call will remain muted throughout the whole presentation. If you have any questions, tech issues, need a comment on something, go ahead and put it in the chat box. If it's a tech issue, I will answer that throughout the call and I'll monitor it. If it's a question, we're going to hold it for the end of the presentation and then we'll read those aloud so that Laura can answer those for us. I will be sending an email out after the presentation that will include any information that needs to be shared throughout the that we talked about throughout the presentation, and also a link to a evaluation. For any social workers that are on the call, please make sure that your display name is both your first and your last name. That helps us to accurately mark your participation. And then also we ask that you fill out that evaluation from the email that we'll send you, and then that's how you will receive your CEU certificate. Alrighty, I will go ahead now and introduce our presenter. This is Laura. She is a registered dietitian and she is the founder of the Seniors Dietitian, where she supports caregivers and families navigating nutrition challenges in dementia. After a decade of working in acute care with seniors, she developed a specialization in uncovering the often overlooked reasons behind poor appetite and unintentional weight loss. This sparked her initiative to create her own online business, which continues to help caregivers move from confusion and frustration to confidence at mealtimes. Through her education, resources, and practical strategies, Laura empowers caregivers to better understand changing eating behaviors and provide supportive, realistic nutrition care for their loved ones. So if y'all are joining our call today and have never heard or seen Laura McDonald, she is present on social media. That actually is how I found her years ago. And we started talking about this presentation today about a year ago. So we've been planning it for a moment. And I encourage y'all to look her up because she does have some good nuggets to share. If anybody needs anything, like I said, put it in the chat, but I will go ahead and pass things off to you, Laura. Thank you for being here today.
Great. Thank you so much, Brooke, for having me. Thank you, everyone, for taking time out of your lunch hour to join. Thank you to the Alzheimer's Services of the Capital Area. As Brooke said, this is a huge passion of mine, and I'm excited to be here and have the chance to share some information and advocate about nutrition. And thank you for joining. So a little bit about me. As Brooke said, I'm a registered dietitian. I actually work in Ontario, Canada. So in Ontario and Canada, to be a dietitian, you have to do 4 years of an undergraduate degree and a Bachelor of Science in nutrition and dietetics specifically. And then you do a year-long internship in a variety of different areas. And then you have an exam to become a dietitian. And then from there, you have yearly upkeep on your professional designation. And it's a protected title, just like doctor and other titles. Whereas perhaps a nutritionist, anyone can call themselves a nutritionist. So I think it's important to understand the background of someone who's speaking today. A little bit more about me. I'm a mom of two kids under 5. And like it said in my introduction, I've worked with seniors and their families for over 10 years in hospital, and a lot of whom have had dementia. And so it's become, a passion of mine, like I said, to support seniors and their caregivers, and understanding the influence of aging and dementia and the relationship with food and nutrition and how they influence each other, and what impact they can play. And like she said, I'm the owner of the business that I've created from this passion, the Seniors Dietitian. So a little bit about my why. So like I said, working with so many seniors, a lot of whom in the later stages, obviously I've seen them earlier on, but when appetite is really changing as it progresses, I started noticing that there was a lot of families who were surprised at some of the effects that dementia had on appetite, and looking back at the progression over time. And I had wished that they had had some information earlier on to support them in their journey. And I work with a lot of wonderful doctors, geriatricians, people specializing working with those 65 plus, and they work both in the hospital and in outpatient clinics. And I would say to them, how much time are you able to spend, like talking about that these relationships with food and dementia. And they said, there's so much to cover in these appointments that there isn't a lot of time to talk about this. And in reality, it's, more of a dietitian specialty, but it's, it became, a hint to me that more people need to be talking about this. So I wanted to help people earlier on to know what to expect, what things you can do to help, and what was a natural part of the disease. So I'm hoping you can get some benefits from this today. So I have no affiliations to disclose. Like I said, I'm registered with the college. And just a reminder, the content of this presentation does not constitute medical advice, and it's for educational, informational purposes only. But please, speak with your doctor, dietitian, professional healthcare team about your own individual and specific dietary, nutritional, and medical needs, because nutrition is very individualized, and some advice that might work for someone might have reasons that it's not appropriate or doesn't work for someone else. Okay, great. So, what we'll cover today is sort of first off, why you're here, who is here. We're going to talk about why eating changes with aging and dementia and a whole bigger picture aspect. We'll talk about some common mealtime struggles and then some ideas of what you can do about it. So from what I understand, there's a big group of people here from a variety of backgrounds and relationships with dementia and Alzheimer's. So perhaps you're a senior here, and welcome. Thank you for coming. Perhaps you're a caregiver to someone, maybe in a professional standpoint, maybe as a spouse, maybe as a child or a grandchild. And I understand there's a lot of social workers and other health professionals here hoping to connect and learn about nutrition. And thank you to all the social workers. You do a lot to help connect patients that I work with different resources, and we work as a team. So I'm happy to have you here as well. So depending on who you are in the room, perhaps you've noticed either with your clients, your loved one, or in yourself, some of these statements. Perhaps if it's you, you might be thinking sometimes, I don't feel that hungry anymore. If it's a loved one, they're losing weight and they're not really trying to, but I've just sort of noticed that change in their body over time. Or maybe they're only reaching for sweets. Perhaps the other end of things where they're eating all day, or they're forgetting to eat at all. And perhaps the foods that used to be their favorite foods aren't their favorite foods anymore. And maybe they just notice that they're slowly eating less and less over time. The portions are getting smaller. Or they're saying things like, I've already eaten, but they haven't actually eaten yet that day. So you're not alone. These struggles are incredibly common with aging and dementia, and it's not stubbornness or just picky eating. And so the first step is going to be understanding, what's happening and then what we can do to help. So we'll look at the why eating changes throughout aging and dementia. So these are just some factors in a bigger picture, and we'll talk about each one of them. So reduced activity, changes to taste and to smell, medications and their effects on the human body, illness of different kinds, chronic diseases, so things that we have that we continue to have throughout our lives. Perhaps one of those illnesses has gotten to the point that you're actually admitted to hospital, and there's those own influences of being in a hospital. Changes to dental health, and then the big one, dementia. And they're all related to each other, so they're worth looking at the bigger picture altogether. So when we think about the first one, we'll talk about reduced physical activity. So compared to middle age, perhaps in a time where you're maybe getting more exercise, working more, moving around in day-to-day life, your body is using more energy to do so. And as we get older, perhaps in retired life, we're doing less physical activity. Maybe some of the things are creeping up like arthritis that's causing moving around and getting exercise to be more painful. And so we're doing less fit. Perhaps we've had a fall and we have a hip injury, or we got a knee replacement, and now getting physical exercise isn't as frequent as it was before, and so maybe it's even social outings that we're doing less. And all of these things, like, we know that exercise and physical activity increases appetite. Our body needs more nutrition to support that exercise. And so with reduced exercise, we see like often a reduction in appetite. So the opposite can be true as well. If you're still able to get around and move throughout your day, go for walks, then that can help with appetite sometimes as well. Next one is changes in our smell and our taste. So there is a reduction and changes with aging that can occur where the amount that we can be sensitive to with smells and taste can go down. We see it more so in dementia, and we'll talk about why with the brain and body connection in a few slides. Medications is another one that we'll talk about. The side effects of medications can influence smell and taste. And then another one like illness, like COVID. We know a lot of people who have lost their smell and taste for a short term or longer term because of something like that. And if we think about it, if things aren't as flavorful, they're less appetizing. It's less appealing to eat when we don't have as much of those sensations. And if you think about, your favorite food right now and think of smelling that food, your mouth might even start to water. So there's interactions with our senses that can be influenced. If we're not smelling and tasting the same, then it makes sense that there might be a change in our appetite. So the next one was medications. So medications are important and valid, and always speak with your physician about your medications. But when we look at it from a nutrition lens, what dietitians look at are what are the influences of those medications on someone and their body related to food. So we think about whether does that medication cause an increase in appetite? Does it cause a decrease in appetite? And are there any other side effects to that medication that can influence our appetite? Whether that be dry mouth, taste changes, like some medications could make someone taste more metallic with their foods or bitter. Are they feeling nauseous because of their medications? Like pain medications, can make you constipated and that can make you nauseous. Perhaps nausea or vomiting is influencing your appetite and how much you're eating. Maybe they're having diarrhea because of one of their medication, and that's influencing them and how much they want to eat, because some people I've seen with diarrhea almost choose to eat less because they don't want to have diarrhea, but then they're not getting enough nutrition. But then when they are eating, if the food is moving very quickly through their digestive tract, their body's not having an opportunity to soak up the nutrition the same way it could if it had the time to go through in a regular amount of time. And then constipation, we see also affecting appetite, because if you feel very full, you're not very hungry. And the constipation can be a really also serious medical condition and cause other issues. So it's an important thing to keep on top of. And these things can be harder to communicate with dementia if it's affecting someone's ability to talk and share how they're feeling in more detail. So it's important as, a caregiver or team member, to be curious about these things. So it's important to just, advocate for yourself or your loved one to your care team, to your doctors, and just say, these are some of the things that I'm experiencing, and sort of see if there is anything they can do to adjust or add something in order to look at the whole picture of the person and make sure we're addressing these issues. Another reason that eating can change throughout aging and dementia is illness. So maybe it's something like a bladder infection, a UTI. We have lots of people coming to hospital with things like that, with pneumonia or upper respiratory tract infections, RSV, the flu. So all of these things can, reduce appetite. And it's sort of the first thing to go I see when seeing someone in hospital. They have something that's making them ill. So and not eating as much. And sometimes they can cause something like delirium. So whether you have a baseline of cognitive impairment or dementia or not, being ill and in hospital can put you at risk for delirium. And that's where it's more of an acute confusion, we say. And that can influence appetite, eating ability, and make it more. People have hyperactive delirium where they have a lot of energy moving around, they can't focus on food, or a hypoactive delirium where they're more drowsy and it's difficult for them to eat. So it can influence and worsen some of those common dementia symptoms, like eating, swallowing, and confusion. And depending on the person, it can be a short-term thing, it can last longer, it could take a while even after they're home to improve. So it is something that can influence appetite. And aside from those, acute illnesses, we have an influence from chronic disease. So the long-term effects and side effects of dealing with diabetes, chronic kidney disease, liver disease, lots of different chronic diseases can influence appetite. And so whether it's the side effect of the disease itself, like we think about diabetes. If they have slow stomach emptying because of their chronic diabetes, that makes them feel full quicker and they're not as hungry as quickly, then that can be, a side effect of the disease. Whereas medications that they're on because of their chronic disease, maybe like I said before, some of those could be influencing different symptoms that affect their appetite. And also, depending on the specific disease itself, they could have specific dietary needs, restrictions, things that they have to follow, like chronic kidney disease. Perhaps they can't eat food too high in potassium. And that can just be a lot to manage. And food, now has this whole other lens to it. And that can, affect appetite as well. And then depending on whether it's chronic or acute illnesses, bringing someone to hospital, I obviously have worked with this a lot. So we see, just being in that place can influence appetite. There's new food. It's not the food that they've been eating at home. It's perhaps they have gotten the wrong diet order. Like maybe at home they're eating pureed food, but they were put on a regular texture when they first came in by mistake, and that has to be adjusted. So they're not able to eat the food well because they need pureed food. Depending on what test they might need for their medical workup, they might not be allowed to eat. You might see NPO, it's a Latin nos per os. They're not allowed to eat before a test, but that's obviously a time that they're not getting nutrition. So it's important to follow the rule, but it's also a time where they're getting less to eat. Perhaps they're not getting the assistance that they need eating. So we can see with dementia over time that the physical ability to feed themselves becomes more challenging. And so if they are at a point where they need support, whether that's verbal cueing, cutting up the food, physically feeding them, spoon feeding them, depending on the nursing ratios and the time, the extra support, PSWs, family that's available to come in and support during meal times, we can see a reduction in how much somebody eats compared to what they might be able to eat at home in those instances. And then in some, illnesses, we see that even though appetite is what we say, the first thing to go when you're ill, often we need a bit more nutrition to help our immune system fight off whatever we're dealing with, and to help ourselves heal. And, what fuels our immune system is the nutrition that we eat. And so sometimes it's communicating that food is also your medicine too. And even if it's not your favorite foods or the way you'd cook it at home, trying to at least eat what you can in order to support your body during that time is important. Another one we look at with aging and dementia is a changing in dental health. So whether teeth are broken or fallen out, whether there's gum or teeth pain, maybe an infection that's causing it to be so sore that they can't chew meat well, and so they're not getting other sources of protein in their diet that are softer. And so looking at that, and we'll talk about those examples. But maybe they fully have dentures, but they've been admitted to hospital and they've left them at home. Perhaps they've experienced some weight loss and the dentures they had don't fit anymore. And so they're starting to take away certain food groups or things that they could normally eat before, without knowing that there are consequences, that if you're not, say eating enough protein, that your muscles are going to start to take that protein they've been storing for their use and put them into the bloodstream for somewhere else. And then we see people with weight loss and more risk of falls. And so it's all connected. And then the big one that we're talking about here is obviously eating changes with dementia. And so we know that the brain, the body, the whole thing is quite magical, in my opinion. The ability of our body to function is such a complex system is amazing. But when we look at the communication that occurs between our brain, our nerves, our organs, our hormones. So there's a complex system, like railway tracks, a train that's moving all throughout our body to communicate. And when there's a breakdown from dementia in those tracks, the train can't get from one station to another. And we can see these effects, often talked about in different organizations, is the planning and organizing of thoughts, physically moving, chewing and swallowing. So I'm going to take you through some examples of what that can look like from the lens of being able to eat independently. So let's think about all the thoughts and actions that need to occur for that to happen, for someone to be able to eat. So thoughts like, I need food in my cupboards. Well, the next thing is, what food do I already have? So maybe that requires you to be able to physically go and walk into the kitchen and look and see what food you've got there. Then let's think, what recipes do I want to make? I have to choose what foods maybe are going to meet some of my health conditions and be balanced and meet the needs of my body. That takes a lot of planning. And then what foods do I need to buy that I don't have in the cupboard? Making a list. Then there's the act of physically getting to the grocery store. Are you still driving? Do you have a partner who drives? Are you taking transit? Who all is involved in that process? And then if you're at the store, is it okay, the energy and endurance, the strength to go around the store, remembering and carrying all the food that you need, and then doing the same to get it home. Then there's preparing, the day of or in advance to open, chop, cook, deal with food safety, and being able to physically do so. Then in the actual moment of a meal, it's remembering that it's time to eat, or remembering that you feel hungry if you're able to do so, and that or remember if you either have or have not eaten already. Then there's the act of plating that food, recognizing, knowing how to use utensils, having the strength to use your arm, having the ability to chew and swallow it safely. And we'll talk more about that in a minute. And then doing the cleaning and storage and keeping up with food safety. And so there's a lot of steps with both the thoughts, the planning, and the actions that we must take for granted that we do in our day-to-day life. And that my job often, what I find is that I'm kind of going through thinking about these thoughts and putting a detective hat on to see, okay, where is the breakdown happening for this individual that's affecting their ability to access food and get food. So it's important to look at that as well and sort of see what's happening for each individual. And so the second to last point there was talking about chewing and swallowing. And so I'll talk about it here and a little bit later as well, is that dementia has a big impact on something called dysphagia. So it's chewing and swallowing problems. And so there's a really complex set of nerves and muscles in our mouth and down our throat all together. And it's a very coordinated system. And so instead of the natural route of chewing and swallowing our food and it going down our esophagus and into our stomach, what we see with dementia and dysphagia is that there could be many reasons why and many areas where the system is breaking down, but someone is, instead of having the food go down the esophagus into the stomach, some of the foods or liquids may be traveling into the airway and into the lungs instead. And those where those two tubes connect, and you can see in that model there. And so what can happen is that food or liquid can carry bacteria with it, and it can cause something called an aspiration pneumonia. There could be a type of pneumonia that is not related to this, but could be from aspiration. And so this is something that we see often as the disease progresses. People come at higher risk for this, and there is involvement of a team member, speech language pathologist. So in Canada, we have a lot of speech language pathologists in our hospitals and in home care settings, so people can do assessments in the community. In some of our rural areas, some of the dietitians are trained in this. They have their own additional training to do that when they don't have access to speech language pathologists. But we'll talk about some signs of where maybe that would be a beneficial care partner to have on your team to get different swallow assessments. So if you're noticing there are signs of dysphagia, that could be things like choking or coughing on food or liquids. It could be consistently throat clearing while they're eating. Perhaps their voice sounds a little bit wet after they've had something, or maybe they're getting admitted to hospital with frequent aspiration pneumonias. So those are some things to look out for. So there we go. There's a lot of reasons, like we talked about, like we mentioned, that the whole person. So it's important to look and take a step back. And so thank you for continuing on through all of these examples of things that can influence appetite throughout aging and dementia. So now we're going to move on to the next section of common mealtime challenges and some practical solutions to go along with them. So I'll go through them really quickly and then we'll talk about them in more detail. So one is, these are not all the challenges, but these are some that we'll talk about today that I see frequently in my practice. So difficulty accessing groceries or meals, not liking foods they used to, choking or coughing on foods or liquids, forgotten they have already eaten, or forgetting to eat. So sort of the opposite scenarios of each other. Maybe it's physically difficult to feed yourself, or no longer using cutlery if that's something within your culture that you were using already. Not everywhere in the world does use cutlery. Low appetite or eating less. And then we'll talk about some dementia-related feeding behaviors. I don't love the word behavior, but it's one we often use. But some examples of things you might see are being really distracted during meal times, or impulsively eating, refusing to open the mouth, it's like pursing the lips, pushing food away, perhaps having some food and then spitting it out, or food is unknowingly spilling from the mouth. Difficulty recognizing and using a straw and doing some things with it. We'll talk about that, are not actually how you use a straw, holding food in the mouth. Sometimes we refer to that as pocketing food, and not swallowing. And some of those are more advanced things that we see with advancing dementias. So, some practical strategies to help. So, if someone is having difficulty accessing groceries or meals, there might be different services that even maybe the social workers can see within the area and connect with dietitians to create a list to help people in their area. We have some in our hospital that we use to give out, but there's lots of things that exist now, which is great. There's grocery store pickup. So maybe the act of getting out of the house and getting to the store is still an activity to do and enjoy doing. Then they have services now, at least where we are, that we can ask for all the groceries online and then put them in a box that they can load in the trunk or just pick up from the front of the store, and they don't have to have the endurance to go around the grocery store, or someone else can do the list and then they can just pick it up. Different grocery delivery services that can provide the food. So it's not a meal, it's just all the uncooked items brought to the house. And maybe it's a meal kit. There's, HelloFresh, lots of different ones where it's just the specific ingredients for that meal. So there's not a lot of extra waste. There might be other ones in your area. Meal delivery services that exist. So in Ontario, we have one meals called Meals on Wheels. Factor Meals, another one I've heard of. Well, there might be other local companies. But the nice thing is with some of those, you can see the nutrition information online. So if there's specific requirements that you need, lower sodium, things like that, then you can look for some options that work for your specific health needs. And there's other things you can do is, if friends and family are asking for ways to help out, then maybe meals is a way that they can support. Maybe they can't go to medical appointments because it needs to be you if you're the caregiver, but maybe, you can all take turns dropping off meals, and you can either create an online document or a sign-up sheet, a physical sheet, if that works. There's a company I found called Meal Train, and this is a snapshot from their website. I haven't used it myself, but I've seen it. And it's just sort of, a way to do this online of creating, identify who's going to get the meals, which dates you're going to sign up for. They can say if there's only certain preferences they have, and then you can share it. So it's a way to do it online. So you can do that on your own, use something like this or other tools, but it can be a way to help just share the load of providing meals for your loved one. Another thing is when it comes to common mealtime struggles is not liking foods that they used to. So you might notice that, your favorite foods aren't your favorite foods anymore. And so this can be a big change, and trying to figure out, okay, been maybe making similar recipes for a long time. And so now it's a change for yourself or for you as a caregiver. So you can try and see whether the plate itself is overwhelming. Some people find a lot of food at one time to be just too much, and it just becomes, like I said, overwhelming. So 6 smaller meals is fine. It doesn't have to be 3 big meals a day. There's lots of different ways to get nutrition in throughout the day. And some people with dementia find one item at a time an easier thing to visually digest and to focus on. And so instead of providing, a large plate of food with all the things, you can break it down to, okay, here's one item, wait a little bit, let them digest, offer a little bit more. And perhaps they're not liking the food they used to because they're experiencing those taste changes that we talked about. So maybe it's just that the food's tasting a little bit bland, and maybe increasing the amount of herbs and spices that you're naturally using in your cooking to create more intense flavors. So maybe just adjusting the recipe could help. Sometimes we see with more advancing dementia as well, there starts to be more of a preference for sweets and or liquids. And so this can be something to see if you're noticing that, and sort of look at it from the lens of, okay, how can I lean into this a little bit? How can I add some sweetness to recipes to still give them some balanced nutrition? So perhaps it's, adding some naturally sweet things that we would put in a meal together, like cranberry sauce on turkey, or maybe it's adding a little bit of sugar into those savory dishes like a chili. Sometimes, if you cook chili a really long time, it starts to caramelize on its own. But sometimes you'll see in recipes they add a bit of brown sugar in order to make it a little bit sweeter sooner. So you can try that. A sweet and sour sauce, raspberry vinaigrette. You can boil down, fresh or frozen berries to make like a homemade jam, and use that and put that onto, your morning toast. And you can make soups that have fruit naturally in them. I've seen apple squash curry recipes to make a soup. So things that are naturally a little bit sweet already. Another thing that I see caregivers do a lot is to switch between, when feeding someone, like offering a sweet item and then offering a savory item, and mixing it up to keep the flavors bold in the mouth, and keep them interested in the meal. Um, and then other ideas, are adding protein into sweet items. So there's a lot of recipes on there online now that you can find that use different either lentils or chickpeas, almond flour in recipes to make it what we call more nutrient dense. So adding protein into a sweeter thing, even black bean brownies, things like that that can add more protein or nutrition into something that is naturally considered a sweet treat. This is an example from a cookbook that I have in my home, and I tried it out the other day, and it was lovely. And it has, some oats and some chickpeas, some flax, peanut butter, and so it was a way to make like a blondie, which is kind of like a brownie, but it had some extra fiber and protein and healthy fat, so it was a nice treat. But it had, some extra nutrition added into it, so you lean into the sweetness. So when it also comes to not liking foods that they used to, sometimes I see it might be a nutrient that pops up a lot. There's different nutrients that I could talk about all day, but one big one is protein. So this could be, you've noticed that they're eating okay generally, but they've just slowly stopped eating the protein items on their meals. And that tends to be often from meat. It's just often consumed. So it could be due to a chewing difficulty. Maybe you're noticing that they're chewing and chewing and chewing the meat, getting some flavor, and then spitting out the rest, or just skipping it. And so protein is important to fuel the building blocks of our muscles. And if we don't have that muscle to support our bodies moving around, falls are more common. And then that can impact someone's long-term, ability to walk and to get around. Protein is also important because it supports our immune system health to fight off all these, different illnesses and colds from kids. You can see the little kids sneezing in the bottom. So it's important for a lot of different things in our body, and those are two common ones. So all these pictures on the other side are different ways to sort of make the protein from whether it's meats or alternatives a little bit softer. So at the top, we've got some shredded chicken. So if you're cooking the meat and then shredding it, it's a bit softer and easier to chew, smaller pieces, and that could be enough to make a change for them to be able to eat it more. Ground meats into meatballs, also a finger food, and we'll talk about that in a minute. Tofu, instead of making it crispy on the outside, perhaps more of a silken or a softer tofu can be an option for those who like that. If nuts are too hard to chew and due to any dental issues, and grinding up them in a blender on your own, or purchasing something like almond flour can be another way to get some protein in. Beans, lentils, whether it's in a soup, a chili, are other ways that are more soft, and they can give you some more nutrition without having to chew a tough piece of meat, and have extra added fiber and different vitamins as well. Cooking methods like instead of a barbecue where you might get a harder outside that might be too tough to chew for chicken, is boiling it and having it a recipe in that way to cook it, and makes it a bit softer and more tender and easier to chew. Another way could be adding extra sauces at mealtime in order to help the moisture in the mouth and make it easier to chew that way as well. And then nut butters was another option there. So. And again, like I said at the beginning of the presentation, protein needs are very individualized. There are certain health conditions like chronic kidney disease where too much protein can be harmful to the kidneys. And, there are sort of guidelines for how much protein a person needs, and there can be too much. So it's sort of finding a balance. But it is one that I see, a nutrient that I see often when I hear what people are eating at home, that they end up decreasing for different reasons. And this is an example of some place you can find some recipes that I like, that I've found, lentils.org. So they have different recipes from a variety of different cultures, different mealtime snacks, of different ways to add in something like lentils. So another resource for you. So the next common mealtime issue, when we talked about the difficulty with chewing and swallowing and dysphagia, and we talked about the signs, a little bit of that, whether it's the coughing or choking on foods or liquids. So if you're noticing this in your loved one, please speak to your doctor and request, a speech language pathologist referral, or other trained professional to assess for any signs of dysphagia. Some of the things they might recommend are either cutting up the food, changing the texture to something like soft, minced, or pureed. And the texture might, the title might change depending on where you are, but they can give you guidelines on what that looks like and what's easiest for your loved one to chew. And it's going to be about finding a balance between what is visually appealing to that person, what is safer for that person, and figuring out what that balance looks like for you. And that's a very individualized conversation to have. But something else that they can also take a look at is maybe that thin liquids are not going well. They're a higher risk for that person of aspiration, so going into the airway instead of into the esophagus. And so different tools that exist are thickening powders or pre-thickened liquids, and that can be a safer way to get liquids in that have a less likely risk of aspiration for that person. So those are some things that they might recommend depending on what their needs are and what their wishes are. So the next mealtime struggle we'll chat about is that perhaps they have forgotten to eat. So maybe the day has gone on and they just haven't thought about it. So if you're able to eat together, then that way it can be, eating is social. So in order to, cue that this is, oh, it's lunchtime. Okay, we're going to sit down and enjoy a meal together. And depending, on what your situation is, you might have to work during the day. So maybe this is an opportunity where if you're involved as a caregiver with the meal preparation, you can ask for neighbors to join in for a meal. They can bring their own food over, and you can just enjoy the social aspect. In Ontario, we have, PSW support through home care. So that's a service that we're in the home, they can come and provide some assistance. And sometimes that assistance is, mealtime setup. Some families I've seen, a log to show them, oh, look, like we were over here for dinner. We've written down, this is what we had, but you haven't had any breakfast yet. So let's eat together. But don't force that. Like some people I find that because it might be conflicting with the person with dementia and what they feel is their own truth and from what their memories at that time. Don't focus on that if that's not working, and just, let's enjoy a meal together now and just move forward. So again, just not trying to force them to eat, but just encouraging them to have a meal or a snack anyways. Another thing you can do is to leave snacks around the house that are shelf stable. So if you're working during the day and you're not able to set them up with food as frequently, and then they're eating smaller meals, and the recommendation from your dietitian maybe was to eat 6 small meals a day. Well, if you're only home for a few of them, maybe there's things that you can leave out that are safe to leave out, whether that's nuts or granola bars, fruit, nutrition supplements are safe while they're sealed. And then it's like for 2 hours once they're open. So different tools that you can use in the toolbox. And perhaps they have forgotten that they already have eaten. And so we see this sometimes where people are still, mobile and able to be in their home, but they think that they haven't eaten anything yet, but they have eaten recently, and they end up having lunch multiple times in the day. So this is a tricky one. I try not to let them, eat alone. And again, be social during meals when you can. Maybe if the setup in the house is, having, some food on the main floor, but maybe there's most of the food in a different, more removed area. Is maybe a strategy that can help, and maybe just redirect them to other activities. If you're visiting at that time and they already had something to eat and they're talking about more food, maybe just opt to play a board game, play cards, watch something, or make use of day programs during those times if you're noticing that, and set them up with a social engagement that isn't centered around food. So perhaps one of the mealtime struggles that you or your loved one are going with, that it's difficult to feed yourself, or they're no longer using cutlery. So there could be lots of different reasons that physically feeding yourself is difficult, whether that's arthritis and the pain and it's difficult to grip. Maybe it's some tremors from dealing with that, and so maybe there's assistive feeding devices that can be used. You can see just a random example one. In the corner, there's lots of different types of adaptive feeding devices. And if you have opportunities to connect with a occupational therapist, I know in Canada, they do feeding assessments where they use a bunch of different tools. They either have weighted utensils, they have ones that have the foam around, that's a bigger grip, it's a bit easier for people to grip when they're feeling really weak. And so that can help people, feed themselves independently for longer and have that, integrity to be able to do that for longer and feel good about that. Perhaps maybe they just need some gentle cueing and prompting during meals. Okay, here, have another bite, or oh, cheers, here you go. Have some water. And perhaps if the physically feeding is challenging, finger foods is a better option. So if you're noticing that they're skipping the fork, but they're trying to pick up rice with their fingers and it's spilling all around, then that can be a sign that, okay, how can I make some of these foods easier for them to pick up so they can still eat what we're serving, but they can, access that with less mess as well. So maybe it looks like examples on the page of egg bites or muffins or rice balls, things like that. You'll see in the corner there's like a sippy cup with a lid. So the two-handled cup can be a bit easier to hang on to. You can use both hands, you could use one, but it's a bit easier for some people where the other cup can spill and get all over them. So they have the ability to hang on a bit easier. And then the lid prevents too much from spilling if that's a hard thing to coordinate. So those are different things you can find online. And then other examples of the finger foods are below. And then when it comes to, low appetite or low intake, unintentional weight loss. So a lot of, the nutrition focus on that is trying to make each bite as nutrition dense as possible. And we do that sort of while also looking at seeking treatment for any factors that could be contributing to that low appetite, like all the things we talked about before, the constipation, nausea, pain, all those things, looking at those as ways of, what's causing the low appetite that we could address. And after you're left with, the low appetite that you have to deal with, it's okay, how do I make what I am eating have more nutrients for every bite? So some simple examples below is, I hear people in the morning have coffee and a piece of toast. And so I encourage people to say, okay, what else do you like that we could add on top of that piece of toast? Is it a nut butter? Is it a gem? Is it some fruit? Is it turning it into, instead of eggs and toast, is it, avocado on that egg and making it a sandwich and trying to increase the calories per every bite? Maybe instead of, just some vegetables, it's also adding, cooking them so they're softer and then adding some heart healthy oils to get some extra calories from the oils as well. An example of, the pasta with tomato sauce. So ways to increase the nutrition from a similar meal, but per bite have more vitamins, minerals, proteins, healthy fats, things like there's a lot of like chickpea or lentil pastas now that exist. There's ones for different types of pasta that are on the market, or if you don't like the flavor of those, there's the recipes that use things like red lentils that dissolve really quickly into the tomato sauce that can make it more have more fiber and protein, or making a bolognese from those nuts and lentils and vegetables in the sauce to make it more hearty. So they're still taking the same amount of bites to chew their food, but they're getting more nutrition for every bite. And then sometimes I hear people preparing smoothies at home, which is great for those who are, again, seeking sweets, have lower appetite, chewing issues, or craving liquids with dementia. But sometimes I hear it's either just water or berries or things like that, but trying to add in, you can sneak a lot of things into a smoothie, whether that's nut butters, spinach blends really well, avocados, green yogurts, milks, and make sure, if you're pardon me, someone who doesn't like milk and using a milk alternative, that it's, fortified with vitamin D, calcium, vitamin B12, all really important nutrients for seniors, and getting extra added protein sources in there. So it's just about thinking about, it doesn't have to be a complete overhaul of what they're eating. It's just sort of looking at what are they eating and what do they like, and what can we try new that is going to make each bite, have more nutrition to it. There we go. Oh, of course, I skipped one more too. There we go. So dementia is a feeding related behavior. So we talked about this. So this is not an exhaustive list, but there's lots of different ways that dementia can influence someone's behavior. So perhaps they're more distracted during mealtime. That might look like they're talking a lot, or they're focused on other things because the TV is on and they're not able to focus on the meal. So making sure that mealtime is a calm environment with minimal distractions, can be social, but having that not be too busy, and sit with them and offer them one thing at a time, like we talked about. Another thing that I have seen in both delirium and dementia is, difficulty with using a straw. So I've seen people just sort of fiddle with it with their tongue in their mouth, bite on the straw, blow bubbles, or not have the awareness or the strength to clasp their mouth over a straw. So perhaps the straw isn't working well. And for some people, a straw can be a higher aspiration risk. Not for everybody, but some people it's unsafe with their dysphagia. But maybe it's just better by a small cup sip, or feeding with a teaspoon, which can take time, but it can be sometimes a recommendation I've seen from speech language pathologists. Another type of behavior that we see is, refusing to open the mouth, pushing food away, and that's them saying that if the body is not hungry, and we do see that change with dementia of that brain body connection where hunger and thirst is reduced, and so that might be their signal to you of like, I'm not hungry right now, and so try another time, give it a break, and then see if there's, again, anything else that's impacting appetite. Maybe at that point, they're not very verbal, but maybe they haven't gone to the bathroom in 4 or 5 days, and that needs to be addressed, and then maybe they'll eat more. Maybe they're feeling unwell and you need to get them checked out. But this may be, a sign, if nothing else, sort of acute is going on, to discuss with their doctor, because they probably aren't eating very much, and ask if it's a later sign of dementia and have some bigger conversations. And the other one that you might see as well is like holding food in the mouth and not swallowing, and this can be a high risk of aspiration, and it's best not to force feed your loved one when they're at that point where they are not opening and accepting the mouth or the food, because if you're putting food in their mouth when they're not opening and wanting to take it, then there's less awareness there for the initiation of an adequate swallow. And so again, it can be a higher risk. And it's also not like following, their signs of telling you what they want if they're not able to verbally do so. So just gently encourage, but don't force. So just want to say, supporting seniors is a team effort, from the individual, yourself, from families, neighbors, church groups, community organizations, meal delivery services, doctors, speech language pathologists, dietitians, occupational therapists, physical therapists, social workers, pharmacists. There's a lot of us who are all here to support. And so if you feel like there's something that's changed in regards to your eating, your nutrition, speak to your team, because there's a lot of different ways that a lot of different healthcare professionals, community members, families can help support. So it's a team effort, and thank you to all of you who are part of that team for yourself and for your loved ones. So that sort of concludes my part of the presentation here. So there are more resources that are online through my business. So the seniorsdietitian.com. So you can take a look at that there if you want to have more information about me and the seniors dietitian. And I also made sort of a summary guide for everyone who's attended today that you can access through the QR code you see on the screen. I called it the Dementia Mealtime Support Guide. And so it's a sort of a summary and application of this other tools and tricks that I'm gifting to you today. So thank you so much for attending.
Thank you so much, Laura. That was excellent, excellent, excellent. I'm trying to get the QR code right now, and it says it's been deactivated for some reason.
Oh, I tested it.
Um,
Check. But yeah, we
so
can always send it out after.
yes, we can send it out and we can put it within the follow-up email as well. So please, everybody, if you would like to ask some questions, we still have a little bit of time for some questions. So if you could go ahead and put those there, and I will read those out, and Laura will answer those for us. Okay, first question. Can you discuss the difference between the MIND diet, Mediterranean diet, and or etc. Regarding Alzheimer's?
For sure. Yeah, I knew this one would come up. So it can be sort of its own talk in and of itself. But so the MIND diet is the Mediterranean DASH diet with neurodegenerative delay. So it's a combination of the Mediterranean diet and the DASH diet. DASH diet happens to be about dietary approaches to reducing hypertension, so high blood pressure. So it's a diet that's being studied to look at whether following a Mediterranean diet, so dealing with, lean proteins, plant-based proteins, high fruits and vegetables, heart-healthy oils, reducing refined sugars, fried foods, and things like that, and having, a well-balanced, healthy diet, and looking at that for dementia and Alzheimer's. So there's ongoing research, and what we know in general is that some risk factors, obviously there's lots of risk factors for different types of dementia, but some risk factors are, cardiovascular disease, hypertension, diabetes. We know that those things put us at higher risk for cognitive decline. And so these dietary styles, we know there's strong evidence to talk about reducing those risks of those diseases. So it goes hand in hand to think that those will help with neurodegenerative delay. So that's where the Mind diet comes from, and that's sort of the general overview of it. But we could do a whole other talk on it.
Yeah, thank you. Thank you for that. And we do have a couple, one or two other presentations that we've had done on the Mind Diet. I will link those. They're a year or two old, but I don't think any of the core information has changed. Maybe some of the research has been updated since then, but I can link to some of those previous presentations in our follow-up email. But that is a really great suggestion, especially for someone who is wanting to reevaluate how either themselves are eating for brain health or how our loved ones are eating. And it's a good guidebook to or a framework to guide you in that.
Totally.
Okay, another question is there was an image of utensils with straps and handles. Is that from a specific website or company? And then if you could also talk about adaptive eating equipment and then where people can access those.
Yeah, so that's not something that I specifically do in my setting. I work closely with occupational therapists who do, like I said, those formal feeding assessments. And there are a variety of tools. That was just one example that I pulled off of Amazon, but there are specific companies that have a variety of different tools, depending on what the needs are. Will depend on what specific utensil will work best for you or your loved one. So if you have the opportunity to reach out to your family doctor and ask for a referral to an occupational therapist who could do a feeding assessment to sort of see what would be the best tool. That way, you're not going out and purchasing a bunch of different tools that might not work well for you and wasting your money on that. But I know like I had said, there are ones where if it's dealing with more of a tremor, there are ones that are heavier to help sort of stabilize while eating. There are other ones that have the foam around the utensil and or the strap to help it just sort of hang on a little bit easier. So if people are feeling weaker and the dexterity is more challenging to hang on to the utensil and it's slipping out, then sometimes those can be helpful. And when those ones aren't, then you can just again do finger foods if you need. And then the cups and things like that can be another resource. So there's a variety depending on what your needs are. And so that would be your best bet to seek those out through those resources.
Yeah, that's excellent answer. Love that. And the person that asked that, I know she's a social worker. So another great suggestion is if you're looking for like examples of those, the online store, I'm not sure if I mean, I'm sure you can access it in Canada as well, but it's alzstore.com. That is one that we reference a lot here. And it is a really good hub for a lot of dementia specific items. So if you're looking for adaptive clothing or adaptive technology or adaptive, like regular everyday equipment, that is a really good resource.
Nice.
Also, definitely our local occupational therapists. Like you said, I know we've had before an occupational therapist who works for Baton Rouge Rehab here, who did a presentation all about adaptive equipment.
Okay.
And there are a million and one inventions out there that, can help in everyday care from putting your shoes on to bathing and, reaching those spots in your back that you can't normally reach and things like that. And just eating is one of those uh, aspects of that could be very well used too. I think that brings up a really good point that I had written down a question about. I find that utilizing adaptive equipment and adaptive utensils helps further instill dignity within our loved ones with dementia. Can you talk about how dignity in eating coincide and how we can further increase dignity as someone declines?
Yeah, I mean, definitely there's these tools that can promote independence for longer. If you think about, you know, your own self going through the journey and no longer being able to feed yourself, like that is a huge change in your day-to-day life. And having even in between where it's just more of a struggle, and that can be probably incredibly frustrating, I would imagine. And to if food is spilling on yourself and filling on your clothing and feeling embarrassed about the process of eating, using these tools to help you in order to, like you said, have dignity during mealtime is really important. And even whether it's using some sort of covering to protect your clothing, but also not referring it to as a bib, right? Because that can seem almost like you're talking to a toddler, and maybe using a different term, just like a protective guard. So having that instead of like a diaper, it's a brief, and little things outside of food, right? Like the terminology matters. And so making sure that, when we're talking to someone with dementia, using these things to treat them with the dignity and respect. And that's why finger food can be another option, because it's less messy. And that way they can still have eating. And becoming dependent on someone for eating can happen quickly. And so trying to encourage them through these tools or support, or just gentle, like hand over hand, to gain back strength when they're ill, and like the verbal cues to help them to do that on their own for as long as possible, I think is important, and a way that we can honor our loved ones and ourselves to order to keep that going for as long as possible. And then when it is at a point where someone isn't able to do it anymore and needs that support on an ongoing basis, is listening to their own cues in their bodies of when they're saying that I've had enough and I don't want that, and saying no. And it can be hard for families if someone is refusing to eat in certain circumstances, even though they want to, because food can feel like a way that families and caregivers have a little bit of, control, for lack of a better word, because the illness, the medications, the hospital, everything, the doctors, it all seems a bit out of control, where food is a way that we can show love and care for someone. And so, but you also have to remember that it is about them. And if they're saying no, and it's at that point where that brain body connection isn't communicating hunger anymore, and they're just saying no, then respecting that as well is a way to show dignity as true.
Thank you. Thank you. So you just brought up finger food, and actually that coincides with our next question. What are some of the finger foods that are the most popular that you see when it comes to people with dementia?
Yeah, so it's sometimes it's just even taking, foods that you might have every day and using recipes that aren't meant to be as finger food, that we'd think of it for this purpose, but just are ways that we can make them, like the egg bites that I showed on there. That's, we can get them everywhere. But it's a way that someone can feel like they're part of eating like everybody else is eating, but it doesn't feel like its own specialized item. So things like that, or obviously there's a range of different, muffins that can exist that aren't so healthy for us, and other ones that can maybe have recipes we can make, like I said, that have some extra added nutrition to them. And maybe the portion size is way too big for them and it feels overwhelming and messy and big, but maybe cooking them in the smaller muffin pan in a smaller portion and offering a couple can be a quick way for them to still feel like it's a regular whole food, but they're able to eat it with ease. So things like that can be really popular. And sometimes it's just having strips of chicken and things that they can dip in a sauce or something like that, as opposed to having to use a utensil, so they can still eat what they're having with everybody else. And you don't have to have its own specialized separate meal for them. But it's things that seem common, but we can apply in this setting that make them still feel like they're part of the regular meal.
Wonderful. Thank you. Okay, two questions that I'm going to kind of smush together in one. Do you have any tricks to encourage more hydration? And then also, what do you think about the gel hydration bites that look like candy? I think they're talking about like the jelly drops that I've seen. What do you think about those? And then, what are any tricks that you have or advice for encouraging more hydration?
Yeah, so hydration can be tricky. Like you say, the thirst can go down over time. And so we can see options of just sort of even leaving water out in the house in different rooms. If maybe instead of going to the kitchen and filling up a glass of water throughout the day in that queue, it can instead just be, okay, you set them up on the chair. Here's a glass of water next to them. Let's put one next to the bed in the bedside. Let's put one in this room it might be hanging out in later, and just having it around and available. And then, a tip I recently had seen online too is that, someone said, instead of saying, here, take a drink, it's just saying, lifting up a cup with them and saying cheers, and then just making it a social thing to incorporate that way. And then little ways, you can add in things like a bit of lemon juice into the water, and having that sour and a little bit of sweet, can trigger some saliva and help just make a flavor change to the water itself, and that can help, especially if you're thickening liquids for someone. Sometimes just thickening plain water can be a little bit unappetizing, so having a little bit more flavor in there can help just make it more appetizing for them to have. So little tricks like that throughout the day, and it all does really add up. So trying, to keep an eye on how much they're doing by just all being part of the team. And so if you have people visiting, or PSWs coming or different appointments, bringing a water bottle with you, encouraging them to offer them something. So all be part of the team. Um, I vaguely have heard about the water drops in sports settings, but I haven't heard them in this realm. And I will take some time to look at those, and I'll have to follow up with that one. But that's something that's good to look into. Thank you.
Yes, I have. I want to say that one of the brands is Jelly Drops, and I've also seen them online. So I appreciate you bringing those up. Okay, it's just now right at the 1 o'clock hour. Laura, did you have any parting words or any advice that you wish everybody could hear about nutrition before we head out?
I just want to say again, thank you for having me. And it is, nutrition is a big part that can get overlooked. And so, being here and advocating, to your teams, to involve dietitians or your patients to seek out dietitians, whether it's through a team in their, family doctor, or whether there's other supports in your community, connecting them, earlier on, even before some things arise, just to do a check-in, because some things don't seem like a problem, but they're actually there, just starting to build up in the background. So we're here to help you along your journey. And so hopefully, you can connect as a team and work together to support each other.
Yes, definitely. Being proactive is always better than, being reactive for sure. Thank you so much, Laura, for your time today. It was an excellent presentation. And I'm glad we were finally able to connect after all of this time. So I'll look for the dementia support guide, and I'll send that out to everybody in the follow-up email. And the evaluation will be in there for any social workers. And thank you all so much for being such a great audience today. And thank you, Laura, for your time. We so appreciate it.
Thank you, Brooke. Thank you, everyone, for joining. Have a great rest of your day.
Thank you. Bye.